Head and neck cancer is an umbrella term that covers a wide range of malignancies. These cancers mainly originate from the pharynx, meaning the throat, the larynx, so the voice box, or from the oral cavity itself. These various cancers of the head and neck actually share a lot of common features. Firstly, the vast majority of them are squamous cell carcinomas, roughly 90% of cases. And secondly, they have some shared risk factors, such as drinking alcohol, smoking tobacco, and chewing betel nut, which is a classic buzzword for exams, as well as infection with the Epstein-Barr virus or the human papillomavirus. HPV infection is actually associated with other squamous cell carcinomas as well, such as cervical or anal cancer. However, the signs and symptoms of head and neck cancer very much depend on the location of the tumour. So tumours in the oral cavity will often present as a non-healing oral ulcer, whereas tumours in the pharynx might cause swallowing issues or even breathing emergencies. And then tumours that are further down in the larynx may instead present with voice alterations because the voice box is being disturbed or cause a neck lump. Now let's move on to investigations. The first thing to always remember is that if you're seeing a patient in an emergency setting, start with an A to E approach. We saw previously that head and neck cancer can cause stridor, so in emergency it's possible. Then take a bedside bloods and imaging approach. By the bedside, the main thing is performing a good examination by inspecting the mouth for oral lesions or palpating the neck for neck lumps and lymphadenopathy, which might indicate metastasis. Bloods aren't all that useful for diagnosing head and neck cancer because there aren't any routine tumour markers, although you can test for the presence of EBV, which is a risk factor. It may also be useful to test thyroid function in order to rule out some of the other differentials for a neck lump. And generally getting a routine set of bloods will be important for assessing the patient's fitness for surgery and other possible interventions down the line. The choice of imaging will depend on the location of the tumour, but usually the gold standard for diagnosing head and neck cancer will be to perform the relevant type of endoscopy, whether it's nasendoscopy or laryngoscopy, and then taking a biopsy of the lesion. After that, further imaging like MRI or PET-CT scans will then be done to stage the cancer. This is what nasendoscopy looks like, and during this camera test, biopsies will be taken once the lesion is identified. In terms of managing head and neck cancer, or any cancer for that matter, the first step will be taking an MDT approach, because a range of different specialties will be involved in the decision making and actually delivering the ongoing care. One of the big decisions that the MDT will make is whether to follow a single treatment or combination treatment pathway. Single treatment involves performing surgery or radiotherapy, whereas combination treatment involves surgery and or chemoradiotherapy. Now, factors like the stage and the location of the cancer will determine which of these treatment pathways is followed, and these factors will also influence what type of surgery is performed. So this could be minimally invasive transoral surgery, which is used for smaller tumours, or actual open surgery may be required for larger tumours or tumours that are located at the back of the mouth or deeper in the throat. For some of the more complex cases, there are some newer targeted molecular therapies and immunotherapy options that can be tried. Unfortunately, there will be a group of patients that have a poor prognosis, and because treatments like surgery and radiotherapy in the head and neck area can have a very negative impact on the quality of life, the most appropriate option for these patients might be palliation.